Okay, welcome everyone. We're so happy to have you here today for our program on heart disease in women in honor of American Heart Month. And this program is presented in partnership with the American Heart Association, and we're grateful for their help and support to make this happen. I am Jenny Starr. I'm the Health and Wellness Specialist for the Kansas City Public Library. And today we are privileged to hear from Dr. Valerie Rader, the Clinical Assistant Professor of Medicine at UMKC. And I will just turn the time over to you, Dr. Rader, for your presentation.
Hi, thank you for having me. I appreciate the opportunity to be here and talk to you all about women and heart disease. It's something that I have developed an interest in. And so first of all, happy Tuesday. So the outline of what we'll talk about today. So first we'll talk about some statistics. We'll then talk about disorders that affect women. Now, not all of these are going to be specific to women, but disorders that affect both men and women also. Prevention, and then also cardiac arrest and cardiopulmonary resuscitation. So just some statistics. So heart disease is the leading cause of death for both men and women. 1 out of every 4 deaths is from heart disease. And 1 person unfortunately dies every 36 seconds in the United States from cardiovascular disease, with coronary disease being the most common form of heart disease. And then 2 out of 10 deaths from coronary artery disease occur in those less than 65 years old. And unfortunately, only about half of women recognize that heart disease is their #1 killer. So this is a map of the United States showing heart disease death rates for women 35 plus. And as you can see, a lot of this is clustered in the southern United States, but it is prevalent in all of the United States. Just to talk about disorders that affect women, again, some of these will also affect men, but some of them will be specific to women. So I also included a couple of historic slides. So just to show how much medicine has changed over time. So angina, some people describe it or say it as angina in women. So, unfortunately, things have changed over time. So this is something that was provided to me by one of my partners, but it says another point to remember is that angina pectoris is like gout, a disease of men and not women. When it does manifest itself in females, as is occasionally the case, it is often so confused with the common and frequent pains in the left side due to flatulence or other causes to which that sex is especially prone that its recognition may be a matter of some difficulty. So thankfully, we've learned a lot over time and recognized that heart disease is actually common in women as well. For some reason, my slide is not advancing. Let's see. Sorry. There we go. So coronary artery disease is actually very common. And so a lot of people will know this as hardening of the arteries. So I've included a few schematics. On the left is a picture of the heart arteries. And so this is a picture of our heart, and the heart arteries sit on top of the heart. We have 3 main arteries, 2 that come off the left that branch off one called the left main. There's the circumflex that goes off to the side, the left anterior descending that feeds the front part of the heart, and then the right coronary artery that supplies the right side of the heart. And these come off the aorta, which is the big blood vessel that comes out of the heart to feed blood to the body. So a normal artery is shaped like a tube, and here it is on what we call cross-section. And so this artery is nice and pristine. There's no significant plaque buildup in this artery. So here is a picture of an artery that is starting to develop plaque, and they've found that plaque can start building up in the arteries as early as our teen years. And so in this artery, you have cholesterol buildup that has started to narrow the artery. And so this is the open part of the blood vessel, and then this is the plaque. So over time, when the blood vessel narrows, this can produce symptoms. So for some people, it's chest pain that they have, or shortness of breath, or fatigue, and the symptoms are typically with activity that they will notice these symptoms. Treatment involves, first of all, medications and lifestyle changes. Lifestyle changes being the first thing that we always recommend for a lot of our disorders that affect the heart. So medications also we will sometimes use, but in some patients, they do require more They do require other therapies, including things like stents or bypass surgery. So stents are pieces of metal that prop open the artery. So how we do these procedures is with a heart catheterization, and they do that by going either through the wrist or the leg into one of the arteries. They thread that artery up to the heart arteries, they inject dye, and then take x-rays to look at the blood vessels to see how narrow they are. And if somebody needs a stent, how they do that is they put the wire across that blockage, they blow up a balloon that has a stent around it, and then they pull the balloon out. And so this is a stent propping open the blood vessel. But for some people, they have blockage in multiple blood vessels. And in that situation, sometimes bypass is a better option. And bypass involves using either veins or arteries from other locations in the body that they tie into the aorta and then bypass the area of blockage down to an area below that to supply blood to the heart that was previously supplied by that area where the blockage is. So heart attacks can happen out of the blue. The medical term is myocardial infarction, and these are most commonly caused by plaque rupture. So another schematic over here. So here's a picture of our plaque in the blood vessel, and it's covered by what's called a fibrous cap. And what can happen, this cap can break open, and when it does, all of this cholesterol is pretty sticky underneath. The blood flowing by it forms a clot on top of that broken area of plaque and forms a clot that blocks off the blood supply through that artery. And that's what causes a heart attack the vast majority of the time. So this is usually treated with a balloon procedure, stents, or sometimes even bypass surgery. So we also have found that some people can have heart attacks without any significant plaque narrowing the blood vessel. And so this is a very technical term that we don't anticipate that you remember, but it's just to say sometimes heart attacks can happen without there being significant plaque buildup. So this usually occurs in approximately 5 to 15% of heart attacks, and this can be more common in women. So the different ways that this can occur, so one is called spasm. So this is a normal blood vessel, and the blood typically flows through that vessel. What happens with spasm is part of that blood vessel clamps down, limiting the blood flow in that area. And so sometimes this will cause symptoms like chest pain, but occasionally we do see heart attacks caused by spasm as well. Another thing that can occur is called spontaneous coronary artery dissection. And so with this, the blood vessel typically has 3 different layers. There's an inner layer, a middle layer, and an outer layer. And what happens is there can be a tear in this inner layer, and the blood that flows through here can get underneath that, and then it propagates this area where the blood has been able to enter and can move down the blood vessel as well. And so this is called a dissection. So it's a tear in the blood vessel. And then another reason people can have heart attacks is a clot can develop in the artery that supplies the heart, but it can also come from a different area. So for instance, there's a heart rhythm problem we'll talk about in a few slides from now called atrial fibrillation that predisposes people to form a blood clot in the heart, and that blood clot can leave the heart going to different areas. And we do sometimes see that go down the heart arteries, causing a heart attack. So heart attack symptoms. So people typically will notice chest pain, but not everybody has chest pain. For some people, it can be pain in their arm, pain in their neck, pain in their back, and sometimes it can also be in the upper abdomen. Now, not everybody has chest pain or pain symptoms, but they can also have shortness of breath. Sometimes they'll have nausea, lightheadedness, vomiting, and sometimes it's just extreme fatigue that they'll notice, or even indigestion or heartburn. And we do sometimes see this in patients where they may not have chest pain symptoms, but it's more indigestion or heartburn. And unfortunately, that can be confused for an issue that may be related to the gut. Now, the differences between men and women for heart attack symptoms, so both are likely to have chest pain symptoms, but women may be more likely to have the other symptoms that I mentioned. So some other disorders that can affect women. So congestive heart failure is one, but this is not specific to women, but I bring it up because it is not uncommon for us to see heart failure. So heart failure means that the heart is unable to maintain adequate circulation of blood. Now, this can have a couple of different forms. So we one of the more common tests that we use to look at the heart is called an echocardiogram, which is an ultrasound of the heart to assess the heart function. So for some patients, the heart function is weak, meaning it doesn't pump normally. It doesn't pump the blood out like it normally would. But for some people, the heart can actually be pumping normally. It's just become stiff over time. And that can also be associated with heart failure. So we label these as heart failure with reduced left ventricular systolic function. That means the heart is weak, or heart failure with preserved left ventricular systolic function, meaning the heart pumps normally, it's just become stiff. So this type of heart failure is actually more common in women when the heart pumps normally but has become stiff. So down here at the bottom is a list of the different causes of the types of heart failure. Now, I will say this part in the middle is overlap between the two, meaning these things can cause both. But I will tell you that sometimes patients with preserved heart function can actually have, this is called ischemic heart disease, meaning blockage-related heart disease. So there's a lot of overlap between these, but things that can cause heart failure, so blockage in the blood vessels, inflammation of the heart, that can sometimes happen from things like viral infections or medications, toxic damage, so what that's referring to, so drug use, things like methamphetamine and cocaine, but also excess alcohol use can also lead the heart pumping function to become weak over time. Hypertension is high blood pressure. People can have abnormal heart rhythms that can affect the heart function, or a significant valve problem. When people are overweight, have diabetes, or have chronic kidney issues, these can all lead to issues with heart failure as well. So congestive heart failure is actually one of the more common things we see within cardiology. And again, not specific to women, it can happen to both men and women. But I just wanted to include that because it is an important heart issue that we see. So there's another disorder called Takotsubo Cardiomyopathy, and this is a really fancy name, and I'm going to walk you through what this means. But Takotsubo actually means an octopus catcher, and cardiomyopathy means a problem with the heart muscle. And you may have heard of this referred to as broken heart syndrome or stress cardiomyopathy. So this is one condition that is more common in women than men. And so the thinking is that there is some either emotional event or physical event that leads to an outpouring of hormones that temporarily weakens the heart. Now, these patients can come to the hospital with symptoms that are very similar to a heart attack. And I included a case just to give you an example of this phenomenon. So this was a 64-year-old woman who had a history of high cholesterol and low thyroid. She initially came in with lightheadedness and fainting a couple of days prior, and then developed shortness of breath. So there's a blood test that we track that can indicate if somebody has heart damage, and hers was elevated. And so again, not everybody has chest pain as a symptom of heart attack. It can just be shortness of breath, but her testing showed evidence of heart damage. Now, I included a couple of EKGs, and I don't expect people to be able to read these, but just as an example, so this is her initial EKG that happened before she ever came to the hospital. This was an old EKG that she had, which was fairly unremarkable. And so I'm going to point out the differences between this old EKG that she had and a new EKG that they took when she came to the hospital. So I'm going to point out the abnormality. So if you pay attention to this area, can you see where I'm pointing with the pointer?
Yes, we can see it.
Okay. So this area after these spikes here, and also over here, as you can see, these are now upside down when they were upright before. And this can indicate that there could be a problem with the blood flow to the heart. So, and we do see this in the setting of people having heart attacks. So this is definitely abnormal when her first EKG or her old EKG was essentially normal. So she was sent for a heart catheterization, and as is mostly typical in people who have this condition, her arteries didn't have significant blockage. She had a little bit of plaque buildup in some areas, but she didn't have any significant blockage that would account for her symptoms or those EKG changes. So this is what we call Takotsubo Cardiomyopathy. And so this is also a picture, not hers, but taken during a heart catheterization. And so this is the heart. which is shaped like a half football, essentially. So in this condition, instead of the heart pumping symmetrically, meaning all of the walls coming in the same way and at the same time, he has a disorder where the base of the heart pumps normally, but the rest of the heart does not. So the tip of the football isn't pumping very well. And so this is classic for this Takotsubo cardiomyopathy. And it got its name because the appearance of it at the time of catheterization can look like an octopus catcher. And so that's what this is. And so some people would know this as a broken heart syndrome. And again, it can happen in people who've had some kind of emotional event. We've heard of people developing this after they've been told of the death of a loved one or a significant physical event. Some people have been in the hospital when they've developed this after having surgery or something like that. And so this is something that's more common in women, but we do see it in men as well. So also to talk about other issues that are that can affect women. So adverse pregnancy outcomes can also affect women long-term and increase their risk of heart disease later in life. So these adverse pregnancy outcomes that women can have, so some of them are related to having high blood pressure during pregnancy or in the period of time after. Some women have been told of toxemia in the past. That's the same thing as preeclampsia. Preeclampsia is actually not uncommon, but it's blood pressure elevation that typically occurs during the latter part of pregnancy or in the first 6 weeks after pregnancy, and it's usually associated with other issues with the organs. But women who've also had diabetes during pregnancy, they've delivered babies early or had small babies, all of these things can increase a woman's risk of having heart disease later on. So they increase the risk of risk factors, so things like high blood pressure, diabetes, and high cholesterol. So they're more likely to have those risk factors, but later on, they're also more likely to develop coronary artery disease, congestive heart failure, stroke, kidney issues, and are at higher risk of cardiovascular death than somebody who did not have these adverse pregnancy outcomes. So another condition that's specific to women is called Peri-Partum Cardiomyopathy. And so peripartum means around the time of delivery, and cardiomyopathy means a weakened heart muscle. And so this can be associated with heart failure. It occurs during the last month of pregnancy or during the first 5 months after birth. The cause is not entirely clear, but there's question whether it may be related to inflammation, spasm of the blood vessels, or a problem with the small parts of the blood vessels that supply our heart. And there has been some concern that genetics may play a role in this also. Now, with this condition, about a third of women will recover, a third of women stabilize, and unfortunately, a third of women worsen with worsening heart function over time. Cancer therapies can also affect the heart, and heart disease can complicate cancer treatments. And so cancer treatments I've listed down here can include chemotherapy. There are things called targeted therapies and also radiation. And so the chemotherapy can sometimes weaken the heart muscle, sometimes can cause inflammation of the heart. Radiation therapy, a lot of times we'll see this in people who've had either breast cancer, lung cancer, or radiation for Hodgkin's lymphoma when they were younger. And so just as an example, older women who survive breast cancer are more likely to die of heart disease than recurrence of the breast cancer. And they say to minimize the risk, you follow the same recommendations for heart protection that you would for other heart problems. So I've put another schematic of the heart, and we'll go over some of the different things that cancer therapies and how they can affect the heart. So radiation therapy can sometimes cause thickening of the sac that surrounds the heart. It's called the pericardium, and it helps to protect our heart. That can become thickened over time. Radiation can also make the heart valves thickened. It can make the heart stiff. It can also, and you can't really see these that well, but the coronary arteries, this is what's called a short axis, or you're looking at it like you've cut a loaf of bread. So the coronary arteries, you can develop coronary artery disease as well. And some people can also develop heart rhythm issues related to cancer therapy and also inflammation of the heart as well. So another condition that can affect and this is both men and women, it's not specific to women, but it's an important thing that we see, and it's not uncommon, as a heart rhythm disorder called atrial fibrillation. And so this is one of the most common types of heart rhythm issues that we see. And so over here on the left is a normal heartbeat. You can see down here on the EKG, the spikes are pretty regular in terms of the distance in between them. So normally what happens, we all have our own pacemaker in our heart that sits in one of the top chambers of the heart, and it sends electricity that spreads through the top chambers and then down to the bottom chambers of the heart in a very coordinated fashion. But instead, when people develop atrial fibrillation, there's a bunch of areas in the top chambers that are all firing at the same time. So it's an irregular rhythm. And so it makes the rhythm down here on your EKG very irregular. And so for some people, the heart can beat too slow with this. Sometimes the heart rate can be normal, but for many patients, the heart can actually beat too quickly. And so, and the symptoms that people would have with this, some people note palpitations, so they feel their heart beating funny. They can also note shortness of breath, lightheadedness, fatigue, or chest pain. And unfortunately, this can lead to complications. So it's a very common cause of stroke because a blood clot can form in one of the top chambers of the heart. And what happens is that blood clot can leave the heart, going to different areas of the body. But by far the most common place that blood clot would travel to is the brain, causing a stroke. And it can also lead to heart failure. So for some people, they may not recognize that they have this rhythm. And over time, if their heart is beating too quickly for too long, that can make the heart weak. And so unfortunately, this can also lead to heart failure. So things that can increase your risk of developing this rhythm, by far the most common risk factor we see is age. But things like having high blood pressure, being overweight or obese can increase your risk. Excess alcohol use, having too much thyroid hormone. People who have heart failure are more likely to have this, and also enlargement of the left-sided chambers of the heart. And then sleep apnea is a big risk factor for this as well. So treatment, just like most of the heart issues that we see, lifestyle changes are the most important. And so we recommend things like weight loss, treatment of sleep apnea, and decreasing alcohol use. So for atrial fibrillation, many patients are also candidates for blood thinners to try to prevent things like stroke. And also we use medications to slow the heart rate or to control the heart rhythm. And for some patients, we treat this with ablation, where they go in and try to burn parts of the heart to get it to go away. So that's another common disorder that we see that's not specific to women, but can happen in women as well. Any questions so far about what I've gone over before we talk about prevention? Okay, so we'll move on. So just to talk about what can we do to try to prevent heart problems from occurring in the first place. So the American Heart Association has recommended what's called Life Simple 7. So these are behaviors and health factors that can help try to reduce your risk of having heart problems in the future. I also added one, which is managing stress. And so the behaviors that we'll talk about: physical activity, avoidance of smoking, working on a healthy diet, maintenance of a healthy weight, controlling cholesterol, controlling blood pressure, and then also controlling your blood sugar. The question is, how much physical activity do you need? So the American Heart Association has recommended trying to get at least 150 minutes per week of moderate intensity activity, or 75 minutes a week of vigorous activity. And so you may ask, what are those, or what would constitute, or what would moderate intensity activity be, or vigorous activity? And in the subsequent slides, I'll go over that. So even just getting up and moving through the day can help. So many people have been working from home since the pandemic started and have become much less active. And so we recommend people try to get up periodically. Some would say maybe trying to get up at least once an hour and move around. And some people can't exercise all that we recommend in one period of time through the day. So if you can even break it up into periods, so maybe exercising 10 minutes at a time, trying to ultimately get up to 30 minutes most days of the week, those are some of the recommendations that we have for activity. So we also recommend that patients add strength training as well. So weightlifting can help build muscle that we tend to lose as we get older. And so exercise can actually help in many regards. It can help our brains and also our bodies. It helps to reduce things like depression and anxiety, but also helps to reduce those risk factors that can lead to heart disease. So it can help maintain a healthy weight, help lower blood pressure, help lower cholesterol, and also blood sugar. So it's beneficial in a number of ways. So moderate activity, so brisk walking, water aerobics, dancing, which can either be ballroom or social, gardening, doubles tennis, or biking at less than 10 miles an hour. And so I included a picture that includes several people. And so when you make this a social event that can help in a number of ways. One, it makes people more accountable if they know that somebody else is relying on them to go for these walks or to do this type of exercise. But social interaction is also very beneficial for our health. And so for some people, they really enjoy walking with other people or exercising with other people. And so this is something just to keep in mind, that having a buddy can sometimes help. So vigorous activity would include things like hiking uphill, running, swimming laps, aerobic type dancing, heavy yard work, singles tennis, biking at more than 10 miles an hour, and also jumping rope. And as I mentioned, also trying to incorporate strength training a couple of times a week can be beneficial as well. So smoking. So I think most know that smoking is not good for patients, and it can increase the risk of multiple cancers, but also increase the risk of blood vessel problems. And so by stopping smoking, this reduces the risk of cardiovascular disease and death. And this risk falls sharply over the first 1 to 2 years after you discontinue smoking. It also reduces inflammation in the body and also decreases the risk of clotting that can sometimes happen in patients who smoke. It improves your cholesterol levels. It slows progression of plaque buildup, not only in the arteries that supply your heart, but arteries in the other parts of the body. For some people, they can develop plaque buildup in the arteries that feed the brain, but also the arteries that supply the legs and other areas. So it also reduces the risk of other blood vessel problems, atrial fibrillation, heart failure, and also sudden cardiac death. Some of the other benefits of quitting smoking. So this can even benefit people who have already been diagnosed with coronary disease or COPD, and it can benefit people at any age, even if they have smoked heavily for a number of years. And so you do have some patients that say, well, I've smoked for 60 years, there's really no point in quitting, but it can still benefit them. And we still try to have people quit smoking, even if it's something that they've been doing for a number of years. I've also included a slide that goes over some ways that people can get assistance on stopping smoking. So there is an 800 Quit Now line that provides coaching as well as a quit plan and also educational materials and referrals. People will sometimes go to individual or group counseling. There's also online resources from the CDC as well as smokefree.gov. There are also texting and mobile app programs. For some people, they need medications to help quit. There's nicotine replacement therapy, such as patches and lozenges, gum, things like that. And then also medical therapy. And I've included a couple of the medications. But for some people, they actually require a combination of both behavioral interventions and also medications to help them quit smoking. So diet, we recommend a Mediterranean type diet, which emphasizes fruits, vegetables, whole grains, beans, and legumes. And we try to limit added sugars, sugary beverages, sodium, processed foods, refined carbohydrates, saturated fats, and fatty meats. And then also using low fat or fat-free dairy products, fish, poultry, olive oil, and nuts. Another diet that can be beneficial that is more focused on trying to reduce the risk of high blood pressure is called the DASH diet. And so this emphasizes things like potassium, magnesium, calcium to try to lower blood pressure and reducing the sodium that we take in. Americans take in very high levels of sodium. And so we try to get people to stay less than 2,000 milligrams of sodium per day to lower blood pressure and also lower their cardiac risk. So alcohol, so we do get questions about alcohol also, and everything in moderation. So for men, we say no more than 1 to 2 drinks a day and no more than 1 for women. So a drink is 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of hard alcohol. So too much alcohol can actually raise your triglycerides, which are the blood fats, and also raise blood pressure. And the excess can increase the risk also for a weakened heart, and also can lead to people having atrial fibrillation, which is that irregular rhythm that I mentioned. So turning now to weight. So this is a map of the rates of obesity in people who are 18 years and older. And so as was similar in the map that we showed for cardiac death earlier. So it's mostly the southern states where the BMIs are highest. And so, and I'll talk about what BMI is in the next slide for those that are not familiar. But if you look at this map, so the blue states here, obesity rates defined by a BMI of 30 or above, there's a lot of patients, and so almost 40% of the patients in these areas are classified as obese. So BMI is what we typically use to define obesity versus normal weight or underweight. And so you can find BMI calculators online. They can be Googled. You put in your height and your weight and it calculates your BMI. And so they classify underweight if your BMI is less than 18.5, normal is up to 24.9, overweight up to 29.9, and obese if your BMI is 30 or greater. So BMI has its limitations. It doesn't take into consideration people who may have more muscle mass, but it also doesn't take into consideration belly fat. And belly fat increases the risk of high blood pressure, diabetes, and also coronary disease. So another way we look at somebody's risk has to do with their waist circumference, and I've listed the abnormal values. So for women, if your waist circumference is over 35 inches, that is abnormal and can indicate higher risk for patients. So cholesterol, so our cholesterol panel has several components. So there's the total cholesterol, the good cholesterol, which has the halo up here, the bad cholesterol, and also triglycerides, which are the blood fats. So the first thing that we always recommend is lifestyle changes. So following a healthy diet, maintenance of a healthy weight, and also exercise. And depending on the patient and their risk, we may recommend medication to try to help lower the cholesterol and also lower their risk. So turning now to blood pressures. So we recommend that patients know their numbers. And so the blood pressure is the pressure of the blood pushing against the walls of the arteries. The top number for blood pressure is the pressure when the heart is pumping, and the bottom number is when the heart relaxes. And so our criteria for what is considered high blood pressure has changed over time. And so it used to be over 140 over 90, and they've lowered it over time to where a normal blood pressure now is actually less than 120 over 80. And if your blood pressure is between 120 and 129, you're considered to have elevated blood pressure. Stage 1 high blood pressure is 130 to 139 with a bottom number between 80 to 89. And stage 2 is if your top number is over 140 and your bottom number is over 90. So high blood pressure may not produce a lot of symptoms, but can still be doing damage to the blood vessels, even if it's not producing symptoms. And that's why it's important to measure. So we do see people sometimes who have not been following their blood pressure and all of a sudden show up with really high blood pressures. And what can happen over time is because the blood pressure may not produce symptoms, it may be creeping up over time, and then it may not produce symptoms until it's really high. But even at lower levels of elevation may still be doing damage to the blood vessels. And having too high blood pressure not only increases the risk of blood vessel damage, but can also damage the eyes and the kidneys, can lead to things like heart attacks and strokes as well. So many people do develop high blood pressure with age, but there are things that can contribute to high blood pressure. So obesity, so being overweight and lack of physical activity can raise somebody's blood pressure. Following a high sodium diet, so cutting back on the sodium for some patients can actually lower the blood pressure. Things like ibuprofen and naproxen can raise blood pressure, and so can excess alcohol use. So blood sugar, so elevated blood sugars can also increase the risk of having heart issues as well. So for some patients, they may not recognize that they have diabetes. So I included some of the symptoms that can indicate that there may be a problem. So patients can sometimes notice that they're more hungry than usual, or they're more thirsty. They may be urinating more. They may lose weight and not be trying. They can also have tingling in their, usually in their feet, that moves up their legs. And they may have been in the hospital or had some kind of testing with their primary care physician and found to have a high blood sugar. But they've also been found to have poor wound healing and increased risk of infections. And so these are some symptoms to look out for. And if you have these, talk to your doctor and make sure that you get tested. So some of the risk factors for diabetes. So age is a risk factor, being overweight, having a family history, being found to have elevated blood sugars in the past that may not necessarily qualify for diabetes, but have been elevated. Physical inactivity can increase your risk. And then also having diabetes when you're pregnant, or having a baby that weighed over 9 pounds. And then certain patients who are of African American, Hispanic, American Indian, or Alaska Native can also be at higher risk. So we screen for diabetes with either a fasting glucose or a measure called A1C, which measures your average blood sugar over approximately 3 months. So management of elevated blood sugar. So first things first, lifestyle changes. So weight loss, dietary changes, increasing the physical activity. And for some people, despite this, they still require medications to lower the blood sugar, whether it be pills or injectable medications like insulin. So stress. So this wasn't in life's simple 7, but it is a significant issue for patients, especially with the pandemic and everything that's going on in the world. People seem to be more stressed. And so this can lead to negative health behaviors, including smoking. We have had patients that when they go through a stressful time, they may have quit smoking in the past, but resume smoking during a stressful time. Can lead to overeating or suboptimal diet, and then some of them end up increasing their weight. They don't exercise as much. They may not be as compliant with their medications as they would otherwise. And this can also lead to physical symptoms as well. So things like headache or back pain, they may notice that they're more fatigued or have digestive issues. And they may also notice that they're more moody, have more anxiety or depression. So different ways that people can manage stress. So exercise is an excellent way to try to help manage stress. So, and it doesn't have to be anything fancy. Walking is perfectly fine, but for some people, they prefer other types of exercise, things like basketball or other activities that involve other people. But it can be as simple as yoga that can also help to manage stress. So even things like meditation and other relaxation techniques can help manage stress. Getting adequate sleep. And so they suggest people get 7 to 9 hours of sleep per night. And too much sleep can actually be detrimental to the health as well. Social activities are really important. And so for some people, just spending time with friends or family, some people volunteer, or church is really important to them. But just trying to participate in social activities, because that can help manage stress as well. Also, hobbies. For some people, they enjoy reading, or they enjoy, like I mentioned, volunteering or woodworking. So hobbies can also help to manage stress as well. And pets can be also helpful. They can also, especially if you have a dog, so when people get a dog, they end up going for more walks, which can help manage stress, but it can also help with their other risk factors as well. Any questions so far before I move on to the last topic?
I have one question in the chat. Mary's
Sure.
asking, do you have any thoughts on the efficacy of using standing desks?
So yes, so they have found that people that sit more have higher heart risk and higher risk of those risk factors. And so yes, we do like standing desks as well. They can be helpful, but we also encourage people to walk around. And so not just standing, but making sure that they're getting some activity during the day as well. Okay. So the last topic we'll talk about is cardiac arrest, as well as CPR, or cardiopulmonary resuscitation. So cardiac arrest. So sudden cardiac arrest is a leading cause of death. And unfortunately, 89% of people with an out of hospital arrest will die. And women are less likely to receive bystander CPR, which is an unfortunate situation. And so the reasons that they gave are the assumption that CPR may be performed differently because of women's breasts, fear of inappropriate touching or exposure, fear of being accused of assault, fear of causing injury, and poor recognition of women suffering a cardiac arrest. So here's another historical slide that was provided to me by one of my partners. And so it's amazing how times have changed. Back in the 1980s, this was felt to be more of a man's disease. And so it was said at that time, if your husband had a heart attack in bed tonight, would you know what to do? And so learn CPR to save your husband's life. So we now know that heart disease is very common both in men and women. And so it's important to try to learn CPR to save anybody's life. So one thing that's really important, and some people hesitate to do CPR when they see somebody because they, number one, they don't know what to do, but they also don't want to do mouth to mouth as part of CPR. And so they also recommend hands-only CPR and say that it's just as effective in the first few minutes outside of the hospital. So with that, I was going to switch over and show a short video on hands-only CPR. This is only about a minute.
If you see a teen or adult suddenly collapse, it's important to act fast. Helping to save a life is easier than you might think. Just start hands-only CPR. The first step is to send someone to call 911 or call 911 yourself. Then get directly over the victim. Put the heel of one hand in the center of the chest, then put your other hand on top of the first. Then push hard and fast in the center of the chest until help arrives. It's important to push, giving 100 to 120 compressions per minute, which is about the same tempo as the song Stayin' Alive. Let's hope you never have to use hands-only CPR. But if you see a teen or adult suddenly collapse, don't be afraid to try it. Remember, call 911, then push hard and fast in the center of the chest until help arrives. Your actions can help save a life.
Can help create 24 life-saving medicines. Make over $1,000.
Okay. The other thing to think about when you see somebody that's down is to see if there's an AED, which is an external defibrillator. And those are actually much more common than they used to be in the past and are in different locations, malls, airports, things like that. And so that's also something to think about as well. Now, some people hesitate to do CPR because they're not sure if they feel a pulse or not. They suggest that if you're not sure if you feel a pulse or not, it's better to try CPR to try to save this person's life, especially if they're unresponsive. So that's something to think about as well. For some reason, it's not going again. There we go. So to learn CPR, so the American Heart Association offers classes in CPR. And one thing I've noticed more recently in several airports is they have a mannequin that you can practice CPR. So this might be helpful for people who travel a lot. And sometimes we have really long layovers in airports. And so it might be something important to try to learn because it could save somebody's life. So this is just a picture of the Heart Institute, and this says Go Red for Women. So this is also a slide courtesy of one of my partners. Any other questions?
Any questions, folks? Okay, so someone says, I recently started an arthritis medication that sources caution as potentially increasing risk of heart disease due to it being a prescription NSAID. Any thoughts for finding the balancing point between 1, I need this for XYZ reasons, but 2, this increases risk?
Yeah, so if it's an NSAID, so the over-the-counter ones are things like ibuprofen, Motrin, Aleve. The prescription ones may be things like celecoxib or meloxicam, medications like those. And so the issue that we have with those medications, so there's multiple different side effects that they can lead to. So it can be anything from blood clots, they can injure the kidneys, they can lead to fluid retention, high blood pressure, also irritate the stomach. And so everything is a risk benefit. And so we try to minimize those medications as much as possible and use the ones that are less likely to cause some of those symptoms. So for instance, things like acetaminophen with a brand name of Tylenol is safer in terms of those symptoms that I just mentioned. Now, we don't want people taking Tylenol in excess because that can lead to liver issues, but trying to find other measures that you can, or other medications or things that you can do to try to minimize pain without having to use the NSAID type medications. And so, but trying to minimize them and then an alternative if there is one.
Okay. Any other questions? And feel free to unmute if you just want to ask your question, or you can use the chat. Dr. Rader, before we started the program, we were talking a little bit about COVID. And one of the questions that I thought I would ask is about vaccines and heart inflammation, because there's been some information. And I think especially for kids, people are concerned about that. What are your thoughts on that?
So one thing we know about the vaccines is that they're very, very effective. So we have to think about, and again, everything is risk and benefit. And so the risk of having inflammation of the heart, it's called myocarditis, is actually very rare with vaccines, with the COVID vaccines. And so, but we do know that the risk of contracting COVID and having a significant outcome if you have COVID is much more likely than the risk of the vaccine. And so we strongly recommend that patients get vaccinated for COVID to try to prevent the complications that can have. That risk of inflammation of the heart is pretty darn low.
Okay, thank you. So we have another question in the chat. It says, do you know why BP taken with the stethoscope in the doctor's office is within guidelines, but the same BP taken in office digitally is often elevated?
So there could be a couple of things. So they're saying the one with the stethoscope is lower than the one with the manual?
Yes.
Yeah. So part of that could potentially be the person taking it. Now, things that can affect blood pressure when patients come into the office, part of it can be how quickly that the technician or whomever is checking the blood pressure checks it. And so for some patients, they've just hurried to get to the office, have rushed into the office because maybe they're running behind or have other issues going on, and they check the blood pressure too soon. So if you haven't rested for enough time, that can make the blood pressure higher. But some of the difference between taking it manually and taking it with a blood pressure machine can sometimes have to do with the person checking it potentially, because they should technically correlate pretty well. Now, we have people bring in their blood pressure cuffs from home, and generally if they're within, and I know you're talking about something different with the blood pressure cuffs in the office, but just for home blood pressure monitoring, because we have patients also say, you know, my blood pressure is lower at home than it is in the office. And if there's a significant discrepancy, one, it could be that patients are nervous when they come into the office. They don't really like coming into the office. It can be factors that I mentioned before. Maybe they were a little behind in getting there, had to rush to get in. Blood pressure was taken too soon after they arrived, hadn't had enough time to rest. So that's one reason that sometimes patients can have higher blood pressure in the office versus at home. The other can be an issue with their cuff. So we typically recommend a cuff that goes over the upper arm, but if there is some question whether their cuff is working appropriately, we'll have them bring it to the office so that we can check it with our blood pressure cuff as well to make sure that they correlate fairly well. And usually if it's within 10 points of each other, then that cuff is okay.
Okay. And then just a follow-up on that, how often do you recommend that folks check their blood pressure?
So it depends on the patient. So For some people who were recently diagnosed with high blood pressure or were adjusting medications or something else is going on, sometimes we'll have them check it more frequently, and sometimes we'll even have them check it every day for a while until we get it under control. Now, in somebody who has blood pressure that is controlled, what I usually tell them is maybe checking it every week or two just to make sure that it's staying controlled. Because like I mentioned, for some people, the blood pressure actually starts increasing over time and they may not recognize it because it's not being checked. And so that's why I still have people check it periodically, even every week or two, just to make sure it's not creeping up and that it's not elevated. But when we're starting new medication or adjusting medications, sometimes we will have them check it every day for a while until we make sure that it's controlled. So when we check blood pressure, we recommend that people rest for at least 5 or 10 minutes. They've gone to the bathroom, so they don't have a full bladder. They haven't recently smoked a cigarette. Their legs are on the ground and uncrossed when they check their blood pressure.
Okay, thank you. And the person who asked about the difference between the stethoscope and then the machine said, in the scenario that it's the person taking the blood pressure measurement, which is more accurate, the one with the machine or the one that the human listened to?
Good question. So if the machines are calibrated, they should be accurate. And so now that's a hard question to answer when they're different. And so most of the time in the office, it's not most of the time, we don't have somebody check it manually and with the automatic blood pressure cuff. Now, in situations that I see that is when the tech has used the automatic cuff, and then I've come in because the blood pressure is high or low, or if it just something seems off, then I'll check it manually. So I don't know if that's the same situation that they're referring to, but most of the time, the technicians don't necessarily check it manually and with an automatic cuff. So I don't know if it's being checked by the technician with an automatic cuff and then the physician's coming in and checking it with a manual cuff. Because most of the time it's not checked with both when patients come into the office.
Right. Okay, thank you.
Part of it, sorry, let me just make one more comment about that. So part of it is, so let's say that the technician is using the automatic cuff and then we come in and check it with the manual cuff. So there could be differences between those, partly because of time. And so if somebody has had their blood pressure checked first thing when they come in, and then after seeing the technician has left, we've come in, had our visit, and then we recheck the blood pressure. Part of the difference could be time also.
That's a really good point. I tend to suffer from some of that anxiety, and so it's always better to check at the end of the appointment for me.
Yeah.
And then we had a question, does an EKG tell if you have the heart problems you spoke of today?
So yes and no. So EKGs are good tools, but there is some limitation in them. So one thing to think about, it's a 6-second tracing. So things could be going on at other times that we're not able to pick up in that brief amount of time. So they do have their limitations. So some things that we can see when from an EKG. So one, we can see heart rhythm issues if they're going on at the time. So for instance, that heart rhythm issue I mentioned, atrial fibrillation, for some people that rhythm comes and goes. For some people it's present all of the time. Now, if we don't happen to be doing an EKG at the time that they're having it, then we may not pick it up. Now, there are other ways that we can look for it with heart monitors. Some people have little devices at home that they can check their heart rhythm or use their watches. So heart rhythm issues we can pick up if they are having an EKG at the time. So if they're noticing palpitations and we do an EKG at that time, sometimes we can pick up on what they're feeling. But if they're not having the rhythm issue at that time, then we may not necessarily pick it up. Other things that we can see from EKGs, so we use them commonly in somebody who comes in with chest pain. So sometimes we can tell from EKGs if somebody is having a heart attack. Now, I will tell you some heart attacks, depending on the blood vessel, may not show up on a typical EKG, and you have to move the leads around in the chest to try to diagnose it. But we use them to diagnose heart attacks. We also use them to diagnose if there's a problem with the blood flow to the heart. Other things that we can see from an EKG, we can see if the heart muscle walls are thickened. So on somebody who has high blood pressure, which makes the heart walls thickened over time because that heart has to squeeze against that high blood pressure, can make the walls of the heart thick. So we can sometimes tell that from an EKG. We can also sometimes see abnormalities that can give us a clue that there may be a certain underlying problem, like a genetic problem. So there are things that we can pick up on it, but it is limited based on how short it is. We can sometimes also tell if somebody's had an old heart attack too.
Interesting. Someone has asked, does it matter which arm you take your blood pressure reading from?
Again, it's kind of like blood pressure cuffs. There shouldn't be a marked difference between the two. And so people can have a little variation. Again, we usually say less than 10 points. So the label that we give is millimeters of mercury. So there really shouldn't be more than a 10 millimeter of mercury difference between the two arms. Now, we do sometimes see a difference between the arms because of a blockage in the blood vessel that supplies the arm. So for some people, they will notice that the blood pressure is markedly lower in one arm and the other, and that can sometimes indicate that there could be a blockage in the blood vessel that supplies that arm, but there really should not be a significant difference.
Okay. Right, that's all of the chat questions. Oh, it looks like I got one more.
Okay.
Okay, it was a follow-up. It said, just an observation that I've noticed and wondered why there is sometimes a difference. Okay.
Was that about the blood pressures in the office?
Yes, yes.
Yeah. So, and without knowing more details, but I wonder if some of that could be that the technician maybe is checking it with an automatic cuff, and then the physician may be checking it manually. And when I see patients, if I have a question about their blood pressure, I check it manually.
That makes sense. Okay. And I know you mentioned today, like keeping an eye on blood pressure, cholesterol, blood glucose, A1C. Are there any additional screenings that you recommend with different ages? You know, just like with other conditions, for example, you always get a mammogram once a year after 40. Yeah. Is there something heart related you recommend?
So there is a test that people can do called a cardio scan. And what that is, it's a low-dose CAT scan that can look for calcium in the blood vessels that supply the heart. Now, not everybody should have this. So we base who should get one in part depending on their risk. So what I mean by that is if you have a 20-year-old woman without any risk factors for coronary disease or plaque buildup problems, then it's unlikely that they're going to show any evidence of plaque on that test. And it also exposes them to radiation. Now, it's not a lot of radiation, but just like everything else, we want to make sure that the benefit of what we're doing outweighs those possible risks. And so and somebody who may have some risk factors for coronary disease. So maybe somebody has high blood pressure, high cholesterol for a while, and they want to know, do I have any plaque in my arteries? A cardio scan can be considered. Now, this, just like an EKG, has its limitations also. So the cardio scan picks up on calcified plaque, so plaque that's gotten hardened over time. And when people have calcified plaque, they also have non-calcified plaque in the arteries, so plaque that is not hardened over time, and that test cannot pick up on that. It just picks up on the calcified plaque. And so that test can help us look at risk for some patients, because if they have really high calcium scores, that can put them at higher risk of having a significant blockage or of things like heart attacks. And so that can be a helpful test in certain patients. So another common test that we use, now we don't do this in everybody, but echocardiograms are probably the most common test that we do in patients. And so it's an ultrasound of the heart where we look to see how well the heart pumps and look at the valves of the heart. Now, we don't really use that as a screening, but when patients come in with complaints that could be related to the heart, that's probably the most common test that we do.
Okay. All right. Well, I'm not seeing any more questions in the chat. We are coming up on our hour of time. I'll just give you one more chance to ask any questions if you have them.